This program is brought to you by Emory University.
Good morning, everybody. Welcome and happy Friday. Thank you for joining us today for Journal Club. We have two of our soon-to-be cardiology graduates, Melroy D'Souza and Tahla Ijaz, who will be presenting on two separate Journal Club articles. We're going to start with Melroy D'Souza, who is joined us. You were an Emory resident. Melroy was an Emory resident, stayed on here for fellowship, and is going to be staying on Emory faculty next year. And he will be followed by Talha, who was in our ABIM investigator pathway, and will be staying in the Atlanta area for his job as well. So I'll let you guys take it away.
Okay. Good morning, everybody. Thanks for joining in. I'm, again, Melroy D'Souza, one of the graduating fellows. These last few months I've been spending on a structural imaging rotation, so I was excited to talk about a journal article about a structural intervention, and this is specifically for the TRILUMINATE trial, which is looking at transcatheter edge-to-edge repair of the tricuspid valve with a TriClip device. So the issue that this sought to address is that TR is becoming more and more recognized as a condition with fairly high morbidity and mortality. If uncorrected, patients tend to develop right heart failure symptoms. Sometimes they're a bit nonspecific, but they can have fatigue, abdominal pain, lower extremity edema, and then when things get bad, of course, it develops a shortness of breath. The sort of mainstay of management seems to be volume control, whether it's diuretics or with dialysis. Then as the disease progresses, patients either don't respond to diuretics or can't tolerate really good dialysis sessions and volume optimization. So this issue can get fairly bad for patients. Looking at the guidelines, the valvular guidelines from 2020 and their sort of recommendations about intervention for TR, the only class 1 indication is if you have symptomatic severe TR and you're getting cardiac surgery for another reason, CABG, maybe left-sided heart valve intervention. Then there's a class 1 recommendation to get tricuspid valve surgery as well. And there's a 2A recommendation if you have symptomatic severe TR, so stage D TR, and you have some complications with right heart failure, there's a 2A recommendation that it's reasonable to do tricuspid intervention. Additionally, if you are going through, again, a cardiac surgery for another reason and you have this sort of progressive but asymptomatic TR, it's reasonable to intervene on the tricuspid valve, either with a repair or replacement at that time. And then a 2B recommendation for patients who are asymptomatic severe, so stage C, but have evidence of right heart dysfunction, might be reasonable to intervene on the tricuspid valve. So there are some guidelines there. The issue, though, is that when TR sort of develops, these patients get really sick. They get comorbid renal failure, liver issues, pulmonary hypertension, RV dysfunction, all of what, one or all of those factors make them at a high surgical risk and make surgery prohibitive. So then there was a growing interest of transcatheter interventions to try to help these patients, which is where the tricuspid clip comes into play. This is an example of the TriClip, which was developed by Abbott. Maybe you're familiar with the mitral clip for the left side. This is sort of the same technology and largely the same device that Abbott then developed to use on the right side on the tricuspid valve. And you'll hear terms either call it TriClip or mitral clip or transcatheter edge-to-edge repair, which goes into sort of the same device, bringing the leaflets together to reduce regurgitation. The device is developed or sort of accessed through the femoral vein. Catheters and sheaths are put up. You don't go transeptal like the mitral clip, and you just go through the right atrium and RV for the TriClip. And imaging is done via fluoroscopy and TEE. And here is a truncated version of the video on the Abbott website, just to orient. The catheter is coming up to the femoral vein, the IVC. It's sitting in the right atrium right now. Here, the operators are directing it to send the device through the valve. They're steering it here to make sure that they have a good trajectory, opening up the arms and orienting it properly. So there are these wing arms that will go on the ventricular side, and then these sort of pointy grippers will grasp the leaflet sort of on the atrial side to get a really nice grasp of those leaflets. Advance the device, bring it on up, put the grippers down, and then those areas of leaflets are sort of cinched between the arms and the grippers for good attachment there. And then you deploy the other side, bring the leaflets together, and by that, you improve coaptation and reduce the severity of regurgitation. theoretically. So with that, the TRILUMINATE trial, which was the initial trial about the TriClip device, was published in 2023 in the New England Journal of Medicine. And in that trial, what they did was they took patients, so they had a N of 350, half of which got the TriClip plus medical management versus controls that were medical management only, and they were sort of split halfway in 175 in each group. The inclusion criteria was that patients had to have severe symptomatic TR, so stage D. Their pulmonary systolic pressures could not be over 70, that's sort of severe pulmonary hypertension range. They had to be on maximally tolerated GMT for heart failure. They did not have an indication for another valvular intervention, whether it's aortic or mitral. They needed to sort of have isolated severe TR and deemed to be intermediate or high surgical risk, therefore making them a candidate for a transcatheter option. Exclusion criteria. So of course, they either had pulmonary pressures over 70, they had a need for a mitral intervention, aortic intervention, or if their LVEF was under 20%. Those were sort of the main exclusion criteria for this trial. It was open label, so those who were randomized to the TriClip group, they got the TriClip and they knew it, versus the medical management group didn't get a sham procedure or anything like that. They just stayed on medications. They had clinical follow-up at 1 month post randomization, or I guess it was post maybe device intervention, which happened about 14 days after randomization. Clinic follow-up at 1 month, 6 months, and 12 months. And at each clinic visit, the patients were assessed for their symptoms, KCCQ, and their 6-minute walk distance. The primary composite endpoint of the first TRILUMINATE trial was a composite of death from any cause or progression to tricuspid surgery, not death from tricuspid surgery, heart failure hospitalizations, and an improvement in their KCCQ questionnaire by 15 points or more. The KCCQ is sort of a questionnaire to assess symptom severity, scales from 0 to 100. The closer you are to 100, the better off you're doing. So they wanted to see, do these patients have improvement in symptoms? Interestingly, so, we're used to these composite outcomes being sort of clustered together, and they get reported, based on the events that happen and a hazard ratio. The authors of this trial chose a statistical technique called the win ratio. And the benefits of the win ratio theoretically is that what they do is, it's not just the first event in the composite endpoint that happens to a patient. They kind of take into consideration everything that happens for a patient, and then they compare it to their counterparts. So for instance, they have a patient in the intervention group. They see, which of these factors, if any, the patients develop, and they compare them to patients in the control group. And in that sort of head-to-head analysis, if the patient in the intervention group, didn't die, didn't need surgery, didn't get hospitalized, and had an improvement in their KCCQ, but their counterpart in the control group had one or more of these factors, that would be determined as a win for the intervention group. And they basically do this comparison between all the patients in the intervention group, all the patients in the control group, and they compare the number of wins in both groups, and they come up with this win ratio. And if the number of wins in the intervention group is significantly higher, then that's sort of determined to be a positive outcome. There's some critiques to using that technique, but the authors for this trial used the win ratio. And then the secondary endpoints were sort of just looking at the safety of the tricuspid intervention, the individual factors of the primary outcome, and then also the change from baseline KCCQ, reduction in TR, and change in 6-minute walk distance. So the results of the first TRILUMINATE trial, the primary outcome, which was that win ratio, saw that the win ratio favored the intervention group. The result was 1.48, which was statistically significant. So, there were many more wins in the intervention group compared to the control group. And then the secondary analyses, so they just looked at sort of the safety or the freedom from MACE after tricuspid intervention, and 96% of patients didn't have any sort of complication after the procedure. The change in KCCQ, just sort of as a raw change in the number, there was kind of more of an improvement in KCCQ in the intervention compared to the control group. The severity of TR was improved in the intervention group. So this is the proportion of patients who had moderate or better meaning moderate or mild TR compared to severe torrential massive. And 87% of patients in the device group had just moderate or mild TR versus only about 5% of patients in the control group had moderate or better TR. And then, 6-minute walk distance, that was not different between the two groups. So big takeaways, it seems like this composite outcome was better favoring the device. However, if you break it down, that sort of difference starts to go away. So taking the components, so death from any cause or need for tricuspid valve surgery, those event rates were largely the same between the intervention and the control group. Rate of heart failure hospitalizations, 0.21 compared to 0.7, was essentially the same between the two groups. So, once they broke it down, they saw that positive win ratio was really driven by the improvements in the KCCQ for those who got the intervention versus the control groups. So the summary for the first TRILUMINATE trial is, after 1 year of results comparing a TriClip to controls was that, patients feel better, but there's not necessarily an improvement of mortality or heart failure hospitalization at the 1 year point. So then after some time goes by, they continue to follow these patients, and they just published the results of the 2-year follow-up for the TRILUMINATE study. This was recently presented at ACC, and it will be in circulation. It's just not in print yet. So we'll talk about this trial for the rest of the study. The design is, essentially the same as the initial TRILUMINATE trial in terms of the inclusion and exclusion criteria. Clinical follow-up and echoes were done again at 30 days, 6 months, 1 month, 6 months, a year, and then for this additional analysis at 2 years. The interesting part that is different for this analysis is that at the 1 year mark, the control patients, if they were symptomatic, not doing well, or chose to, they were then allowed to cross over and get the tricuspid intervention. So we'll talk about the impact on the data a little bit later on. The endpoints for the 2-year analysis is they chose heart failure hospitalizations, both the number of hospitalizations and the sort of hospitalization rate over the 2 years. And then a composite endpoint, which looked at freedom from mortality, need for tricuspid surgery, or need for tricuspid intervention at that 2-year mark. And additionally, secondary analyses looked at the improvements or changes in KCCQ and TR severity. We'll go over sort of the table 1 in a bit, but like just a big overview, 60% of female patients were enrolled. Over half of the patients had NYHA class 3 or 4 symptoms. About 70% of patients had massive or torrential TR. In the device group, they had enrolled and followed more patients to the 2-year mark. So, more basically even numbers of patients, but more patients than went into the first analysis. So here's sort of the table 1 comparing baseline characteristics. All these tables are, it's not in print yet, so they don't look as pretty as when they're printed, but the information's here. So just some relevant, I think, comorbid conditions across the two groups. The presence of atrial fibrillation, fairly high in this population, but maybe relatively similar between the device and the control groups. The presence of kidney dysfunction seems to be fairly equal. About a third of patients in both groups had kidney issues. Need for prior aortic or mitral intervention was about a third again, and even between two groups. The baseline KCCQ score, sort of in this moderate score in the 50s, was even between the two. The NYHA classification of sort of 3 or 4 in the severe end of the spectrum was the proportion of patients with severe symptoms were the same in both groups. And the 6-minute walk distance to start was fairly similar between both groups. And the GFR on the bottom shows that there was mild renal dysfunction on average between both groups, patients in both groups. And then looking at echo and hemodynamic parameters at the start of the study. So again, going back to time 0, LV systolic function was largely normal between the groups. The etiology of tricuspid regurgitation was largely a functional etiology. Baseline TR severity. So, we said on the last slide that 70% of patients in both groups had either massive or torrential TR. So, on the more severe end of the spectrum, and this sort of breaks that down. RV systolic function here as a surrogate using the RV TAPSE. RV systolic function was, normal or maybe just borderline abnormal, but basically no development of RV failure yet in this patient population. Tricuspid annular diameter, mildly dilated, a little bit over 4 centimeters, fairly consistent across. And then the pulmonary artery systolic pressure was about 40 millimeters of mercury in both groups. So, overall, so a slightly sicker population with high prevalence of atrial fibrillation, moderate prevalence of kidney disease, and massive to severe TR. So, sort of a mild to moderately sick population going into this study. So what did they find? So the first outcome was looking at the effect on hospitalization, and they found that the annualized heart failure hospitalization favored the device groups. The hazard ratio for those for the study was 0.72, favoring the device group, about a 28% relative risk reduction, favoring the device for those who got the TriClip. And then also looking at rate of heart failure hospitalizations and sort of how that evolved over the first 2 years, that also favored the device group. The rate was about 0.19 events per patient year in the device group versus 0.26 events per patient year in the control group, and that was a statistically significant difference. So compared to the 1-year analysis, the 2-year analysis seems to have an improvement in hospitalizations for favoring the TriClip. And here's sort of the results plotted out. The blue bars represent the device group, and the red bars represent the control groups. We can see that the annualized heart failure hospitalization rate was better in the device group. And then plotting from time 0 all the way up to 2 years, the curves maybe start to separate at the 12 to 18 month mark. And at the 2-year mark of the analysis, that favored the device group. Then looking at the other composite outcome for this one is the freedom from all-cause mortality, tricuspid surgery, or need for tricuspid intervention. The composite outcome favored the device group. So, the patients in the device group, 78% of them were free from dying, needing surgery, needing valve intervention, whereas only about 30% of patients in the control group were free from these issues. But, again, if you break down the composite outcome, and you looked at just all-cause mortality, that was the same between two groups, 82% versus 83%. Freedom from need for tricuspid surgery were the same between the two groups, 97% versus 95%. So the difference in this composite outcome was again driven by this variable of freedom from tricuspid valve intervention, which in the device group was 96% versus in the control group was 38%. And I know I talked about some patients were allowed to cross over in the study. So, we'll come back to kind of interested why they included this variable in the analysis. But, again, the composite outcome was positive, but it was driven from the need of intervention from the control group. And this is a nice plot of that sort of composite outcome where at the 1-year mark, so 365 days right here, there was no difference in mortality, need for surgery, need for intervention between the two groups. But something happens at 1 year and the curve for the control group really drops off. So, a lot of them are needing something, either they're dying or they need surgery, they need intervention. And we know from the prior slide that this difference is really driven by the need for intervention in the control group. Curves here that just look at the all-cause mortality and the need for tricuspid valve surgery extending out to 2 years. And as you can see here, there's no real difference. And again, the difference came from the need for tricuspid intervention. So now let's talk about this crossover cohort. So what they did was, they followed these patients from time 0, time of randomization, up to 1 year, and we looked at those results earlier. And then at the 1-year mark, for patients in the control group who were, sort of failing medical therapy, they had, increase in their diuretic dose, still not doing well, maybe had a lower KCCQ score, maybe had more TR severity. They allowed those patients to then cross over and get the TriClip device. And there was a fairly high crossover rate. There was, in the control cohort, there was 241 eligible patients at the 1-year mark, out of which 60% of those patients then crossed over and got the TriClip by the end of 2 years. And most of those patients who crossed over got the TriClip somewhere around 12 to 18 months. 92% of those patients got the TriClip between 12 and 18 months. And then, so then if you go back to the 1-year mark and look at, how were those patients in the control groups, those who crossed over versus those who did not, how were their sort of profile compared to each other? So for those who eventually crossed over, about 50% of them had NYHA class 3 or 4 symptoms versus only 30% in the controls had severe symptoms. And there was also higher rates in those who eventually crossed over of torrential TR. So 2/3 of patients who ended up crossing over had torrential TR, versus only 40% of patients who did not cross over had torrential TR. So, these patients developed symptoms, progressed with symptoms, and had torrential TR. And, those are sort of the characteristics of the patients who ended up crossing over. And then those who ended up crossing over, didn't have an improvement in their KCCQ at the 1-year mark. They had worsening 6-minute walk distance at the 1-year mark and a higher rate of heart failure hospitalization at the 1-year mark compared to those who did not cross over. So, kind of rationally so, those who were sicker ended up crossing over. Now, if you go back in time to time 0 and looked at the baseline characteristics of everybody in the control group, those who crossed over plus those who were peer controls, meaning they didn't cross over, their parameters are not vastly different. The peer controls actually had maybe slightly more kidney dysfunction. Torrential TR was at the baseline similar between two groups. RV function at the baseline was similar between two groups, and the KCCQ score was similar between two groups. So something happened between the time 0 and 1 year that made the crossover group perhaps get a little bit sicker and then need an intervention. So the pure control, so those who were assigned, randomized to the control group and who did not cross over at the 2-year mark, there's only 57 patients in that group. 40% of those patients saw a reduction in TR. There was small improvements in their KCCQ score on average. And then the annualized heart failure hospitalization rate was 0.08 in year 1, but did get worse by the end of year 2. So, these patients are also getting a little bit sicker. And maybe as we extend out this analysis, maybe those patients in the pure control group will also start to cross over and need intervention. And then this is like at the 1-year mark, not to belabor the point, but the crossover group starts to get sicker at the 1-year mark. We know that torrential TR was the same at baseline, but at 1-year mark, they had more torrential TR. They had, more proportion of patients had class 3 or 4 symptoms. So something happened in that year that made them progress and get sicker. So then looking at TR severity of the TriClip compared to controls, the clip reduces regurgitation, and that's what we see here. So this left side is purely looking at the interventional group. About half of them started off with torrential TR. Actually, combining massive and torrential TR, 2/3 of patients started with the most severe ends of TR. And as we see after intervention, the percent of patients with severe or torrential TR is 3% and 4%. So the TriClip was successful at reducing the severity of TR. And then looking at the control group, so those in crossover, so of course from time 0 to 1 year, they didn't cross over. So, the higher proportion of torrential and severe TR sort of carried through to 1 year, but after they got an intervention, they also had a significant reduction of tricuspid regurgitation. So this is sort of interesting because whether you got intervened on at time 0 or whether you got intervened on at 1 year, you still saw the benefit of tricuspid regurgitation, kind of a similar proportion. And those in the pure control group, so they never crossed over, they still have a high proportion of massive and torrential TR, maybe a little bit better by the 2-year mark, but largely their profile of TR severity remains the same. And then looking at the KCCQ score, and of course, that was the main driver of the benefits seen at the 1-year mark. Device group is in blue, controls are in red, and those crossover controls are in this dashed red. So compared to baseline and 1 year, we see a significant improvement in KCCQ score in those in the intervention group, and those benefits sort of carried out to year 2. In the control group, they were similar at baseline. They deviated at 1 year because we know that crossover population got a little bit sicker. And then they sort of caught up after those crossover patients got an intervention, and those crossover patients almost had similar KCCQ profiles to those in the initial intervention group. So just discussion of these results. So carrying out the analysis to 2 years now, we see a benefit in the TriClip for KCCQ symptoms. We see a benefit in TR reduction. And then this analysis now showed us that we have a benefit with heart failure hospitalizations as well that favors the TriClip. There still is no mortality benefit seen with the device. The part that makes it challenging for me to sort of conceptualize this is the high crossover rate for a couple of reasons. One is because, the patient, this was done with an intention to treat analysis. So even though a massive amount of patients, 60% of patients in the control group ended up crossing over, they were still sort of treated as control. So I think that could attenuate the impact on hospitalizations and on mortality. Maybe there still wouldn't be a mortality benefit, but perhaps the benefit on hospitalizations could be larger if those patients in the control group never did cross over, as we saw in the year one. So that sort of crossing over makes us a little bit challenging to interpret. But it's a very kind of realistic approach, is where you have patients that are getting worse, and we saw those patients get worse from time 0 to 1 year, and then you let them get this intervention, and some of them felt better after. So that is a benefit of letting people cross over. I think largely this says what I mentioned before. And then the last point, even getting the TriClip in a delayed fashion, meaning at 1 year as opposed to being randomized at time 0, they still had a benefit in TR severity and then in quality of life as well. So my takeaways after these 2 trials so far is, I think clinically we have this experience that, isolated, or at least, having tricuspid regurgitation as sort of a main valvular issue is a challenging disease to deal with, because usually there's a lot of comorbid and secondary effects that come along with it: pulmonary hypertension, renal dysfunction, maybe left heart dysfunction as well. So, intervening or medically managing and then intervening TR is challenging. I'm curious what the analysis will show, because they're going to continue looking at it every year up to 5 years. And, do those curves actually start to separate for mortality, or do the effect on heart failure hospitalization start to improve? Maybe at year 3 or 4 now, do we see the KCCQ actually goes back to being even between the controls and the device groups? And maybe you lose some of that benefit that we saw earlier on. Whether I would offer this to my patients, I think overall I would, just because it seems like severe torrential TR does bring with it a lot of symptoms, a lot of comorbid issues for patients. Some of these patients, are on dialysis, and they're not candidates for something like a transcatheter tricuspid valve replacement. They're not a candidate for surgical replacement. And, I'd have an honest conversation with them that, this would primarily be to improve their symptoms and improve their quality of life, both with symptoms and maybe keeping them out of the hospital. But I think it's a safe procedure, as we've seen over the 2 trials. And if it's sort of medical management was failing, I would think offer this to my patients. But also I'd be interested to know about the demographics of those pure controls, those 57 or so patients who did not need intervention even after 2 years. What baseline characteristics, or maybe what parameters of them really help them not need an intervention? Because perhaps there's some interventions or touch points with those patients that we could learn from and try to keep our patients from not progressing or needing intervention. And that's all I have. Should we do questions and comments now, or at the end, Dr. Coley?
Yeah, why don't we do questions and comments now? And I was just going to say thanks for presenting a very interesting trial. TR is, as you said, very challenging. I was wondering if was the KCCQ the only thing that they looked at for functional outcomes, or did they do like a 6-minute walk test or anything like that?
They did do a 6-minute walk test. I didn't see the results of that on the 2-year follow-up, but let me see if it's still up here. They did it at 1 year, and there was actually here. There was, all the patients sort of declined in the 6-minute walk test, but the tricuspid intervention patients declined a little bit less, but there was largely no difference between the 2.
Okay, thanks. We'll open it up for questions.
I have a quick comment. Great presentation, and really interesting topic. 2 things that they're really not for this trial, but I think that we should always pay attention to in any trial that has heart failure hospitalizations and quality of life as an endpoint. First, for heart failure hospitalizations, I think we should pay no attention to heart failure hospitalization data unless total hospitalization data is presented right next to it. It's a real loss. In fact, it's a meaningless endpoint to look at heart failure hospitalizations if you don't know what total hospitalizations do. And unfortunately, when you look at the major trials in cardiology, 50% of the time that they present heart failure hospitalizations, they don't present total hospitalizations, and it's a real loss, and you really don't understand that outcome at all without the total hospitalization. So I think big picture, whether it's this trial or heart failure trials or whatever trial, we should pay no attention to heart failure hospitalizations unless the next line you also show total hospitalizations. Secondly, with quality of life endpoints, I think what we're learning is that we should pay no attention to that without a sham. And so we really have to push our interventional community, whether it's for coronary intervention, structural intervention, pulmonary embolism intervention, any intervention, we should say, if we're doing this for quality of life, it should be against a sham control. And until we know that quality of life improves against shams, we really can't say anything. It probably would work. If you did a nice sham controlled trial of this, you would probably, and then you really held your groups, you would probably see that this works fantastic. But this is a real missed opportunity. And when we don't have sham controlled and we look at quality of life as an endpoint, we're really off the, we don't really know what we're talking about. And if we show heart failure hospitalizations, we have to show total hospitalizations.
Yeah, I think those are great points, Dr. McDaniel. Which is why I wonder if over time, maybe the quality of life metrics start to even out after that initial benefit.
Hey, Melroy, this is Patrick. We're here in the CT reading room. Great job. So question for you, a lot of these patients have atrial fibrillation, right? And this is kind of the end game, either with MR, TR, looking at these trials and seeing a lot of these patients now. First question is, would you be more aggressive with rhythm control for a lot of your patients to prevent this long term? And second question is, with all these patients with massive interventional, are we waiting too long for some of these patients? And they kind of end stage by the time they've, developed liver dysfunction and kidney dysfunction and all these kind of downstream, end organ kind of dysfunction. So yeah, those are my two questions for you.
Yeah, I think the atrial fibrillation is a good point. We know from, I guess, like East Afnet 4 and other trials that overall outcomes are better with early rhythm control strategies. And, I don't believe specifically they looked at the sort of comorbid MR and TR that comes with atrial fibrillation. But I think, yeah, being aggressive with rhythm control, whether it's, cardioversions or medications or ablations earlier on before these atria massively dilate and cause torrential TR, severe MR. Yes, I think from my practice, coming into fellowship, I think we, we're taught sort of firm trial and residency and just, let's just rate control, but then learning more and with some recent data, being more aggressive with rhythm control is good from a, general heart failure population or keeping patients at the hospital, but then also learning more about valvular disease and seeing some of the complications of longstanding AFib and valvular disease. My practice will be to, rhythm control and restore sinus rhythm as early as possible. So yes, I think this is important to know. And then, do we wait too long on tricuspid regurgitation? I think so. I mean, it's another thing where it was practice changing for me going through, my time in structural, is because I sort of thought about tricuspid regurgitation almost as like a downstream consequence of left-sided dysfunction, pulmonary hypertension, and yeah, the TR are just bad, but let's focus on these other things. But once you're in that cascade where, yeah, you might have those other factors, but if now you're dilating your right heart, you're dilating your annulus, you're causing severe TR, that's only going to accelerate I feel like the morbidity and the mortality that's associated with whatever underlying condition there is. So yeah, I think, maybe historically we are waiting too late. And I think the early TRILUMINATE trials and TRISCEND trial was also talking about, okay, now we are starting to pay more attention to the tricuspid valve, and maybe we don't have great data. But yes, if we identify these complications and treat tricuspid valve, maybe it's just the same that we treat the mitral and the aortic valve in terms of earlier intervention, maybe not while they're asymptomatic, but perhaps earlier intervention that we're traditionally used to. Hopefully we can sort of break the cycle and not wait till patients develop those comorbid liver, kidney issues, maybe left-sided heart issues before intervening. Because as we can see, these patients right here already start off at a very sick baseline. So, maybe our gains once they're so sick are not as meaningful as if we had early intervention. I think without running too far over, I want to transition it to Tahla.
All right, thank you. So I think most of you have met me. I'm Tahla, last year of training here at Emory. I have no disclosures. Just a brief outline of my talk today. I'll start off by going over the 2025 ACC/AHA guideline recommendations for lipid-lowering therapy after acute coronary syndrome. Then delve a little bit into the mechanisms of the different medications that we have available for lipid lowering. I'll go over a couple of clinical trials that have helped to set the standards for lipid-lowering therapy. And the last portion would be the discussion on the Journal Club article I'm presenting. So 2025 ACC and AHA guidelines came out earlier this year, and they do discuss lipid lowering as part of treatment plan for acute coronary syndrome. And, in this guideline, they make a class 1A recommendation of starting high intensity therapy after, an ACS event. And if somebody who's already on a maximally tolerated statin therapy and LDL is still greater than 70, they suggest adding a non-statin agent to further reduce the risk of MACE. And they get into the class 2 category in patients who have acute coronary syndrome already on maximal tolerated statin therapy with LDL cholesterol between 55 and 69, in which adding a non-statin therapy becomes reasonable to reduce the risk of another coronary event. And it's 2B recommendations in patients who have an initial ACS event to concurrently add ezetimibe to a high-intensity statin to reduce the risk of MACE. So just a breakdown of what may happen as a patient present to the hospital with ACS. Initially, it's recommended to get a baseline lipid profile and to start patient on a patient who's not on a lower moderate intensity statin to start on a high intensity statin. At this point in time, it's class 2B recommendation that Zetia can be added. If a patient's already on a maximum tolerated statin therapy and their LDL is less than 55, you continue that high intensity statin. If it's between 55 and 69, a non-statin therapy can be added and it's reasonable as a class 2A recommendation. And if it's greater than 70, definitely adding a non-statin therapy is recommended. For patients who are intolerant or refuse a statin therapy, adding a non-statin therapy is also highly recommended. And then basically reassessing the results of the statin therapy 4 to 8 weeks out to see if you have achieved the goal of lowering the LDL cholesterol below 70 or not, and then tackling that as it may be at that point in time. There are multiple medications that are used to target lipids. And in addition to statins, that includes ezetimibe, which I'll be talking about as part of my journal club. This is a NPC1L1 cholesterol absorption inhibitor, lowers cholesterol about 15 to 25%. Then you have a couple of other newer agents, monoclonal antibodies against PCSK9 that are known to decrease cholesterol by approximately 60%, both evolocumab and alirocumab. And then a newer agent known as inclisiran, which is a silencing RNA against PCSK9 that is still undergoing clinical trials to look at heart outcomes. And another newer agent known as bempedoic acid, which is ATP citrate lyase inhibitor that works upstream of the HMG-CoA synthetase in the cholesterol pathway, and it's been shown to reduce LDL cholesterol by about 20%. So in this image, kind of just summarizes the different mechanisms of action of these different drugs. So in the cholesterol synthesis that takes place in the hepatocyte, cholesterol is made from citrate, and one of the first enzymes utilized in this process is the ATP citrate lyase. And bempedoic acid is an inhibitor of this enzyme in this pathway. Further downstream, HMG-CoA that gets converted to mevalonate it occurs via the HMG-CoA reductase, which is a target for statin therapy. And further downstream of that, as cholesterol is secreted out into circulation, one of the genes that have been shown to regulate cholesterol or LDL cholesterol receptor is PCSK9. So this PCSK protein is secreted by the hepatocyte. It binds to the LDL receptor and helps to downregulate it. The PCSK9 inhibitors out in the market, they basically decrease PCSK9 protein, allowing the hepatocytes to keep the LDL receptor upregulated on their surface and thereby lower the total circulating LDL. And lastly, Zetia or ezetimibe is a inhibitor of this transport protein on the microvilli in the small intestine. The transport proteins, the NPC1L1. Ezetimibe inhibits this transport protein, thereby decreasing absorption of LDL cholesterol, thereby upregulating hepatocyte LDL receptors and decreasing circulating LDL. So one of the first trials that looked at addition of ezetimibe to background of statin therapy was this IMPROVE-IT trial that published in 2015. And in this clinical trial, which was a double-blind randomized trial, about 18,000 patients were randomized to receive simvastatin 40 milligrams or a combination therapy of simvastatin plus ezetimibe after having a myocardial infarction event, and this therapy was started within 10 days of that event. A composite of cardiovascular death, MI, angina, or coronary vascularization was followed for up to 6 years. And the results essentially showed that combination therapy reduced LDL cholesterol by about 15 milligram per deciliter, but more significantly reduced relative risk of cardiovascular events by about 6% over that time period. Another trial that looked at combination therapy was this Odyssey Outcomes trial. Again, a double-blind randomized controlled trial of about over the 18,000 patients, in which patients who have had an acute coronary syndrome within 1 to 2 previous months and were already on high-intensity statin were included. They've had to have a minimum LDL of 70 milligram per deciliter and non-HDL cholesterol of at least 100. As I said, already on high-intensity statin therapy, and they were randomized to either receiving placebo or alirocumab, which is a PCSK9 inhibitor, sub-Q injections every 2 weeks. The primary endpoints were cardiovascular death, MI, stroke, or unstable angina. And again, in this trial as well, they saw a significant reduction in LDL cholesterol by about 26 milligram per deciliter and a relative risk reduction of cardiovascular events by about 15% over 4 years. So as this the background, the investigators who published the study I'm presenting, they were really wanting to know if this recommendation by both the European guidelines and American guidelines of a stepwise approach of adding a combination therapy, 4 to 6 weeks out after initial ACS event is more effective, or having this combination therapy started right at onset of an ACN event really is more effective at preventing another coronary syndrome. Secondly, they were interested in knowing if patients who are on high-intensity statins alone really achieve their LDL goals, or do they actually need a combination therapy approach to achieve LDL, target LDL levels. And currently, as I mentioned, ezetimibe addition to high-intensity statins a 2B recommendation, and they wondered if this should be changed to a higher category. The article I'm reviewing today is basically was published this last month in April of 2025 in JACC, and titled Early Ezetimibe Initiation After MI Might Protect Against Later Cardiovascular Events. So this is a Sweetheart registry analysis. So this study comes out of Sweden, where Sweetheart registry is a large registry that captures multiple registries within the healthcare system there, including all hospitalizations due to MI, prescription data sets, and discharge data sets. Also, as importantly, the registry captures all causes of death that occur within Sweden. This registry analysis by the authors basically looked at lipid-lowering therapy naive patients, about 35,000 of them, that presented to the hospital in Sweden for an MI between 2015 and 2022, and they were discharged on statin therapy. These patients were ages between 18 to 80 years old. Anybody above the age of 80 was excluded. Other exclusion criteria included patients already on statin therapy, on ezetimibe or PCSK9 before admission, if they had an LDL cholesterol that was already below 55, or if they had been diagnosed with hypercholesterolemia, familial hypercholesterolemia. This was a prospective observation study. Patients were categorized into being started on ezetimibe less than 20 weeks after discharge, between 13 weeks and 16 months after discharge, or not started on ezetimibe at all. To reduce various confounding factors and biases, they utilize a novel methodology known as clone sensor weight analysis, and also Cox proportional hazard model. Their analysis looked at MACE, or major adverse cardiovascular events, which included MI, stroke, or death, all-cause death, and then also subcategorized components of MACE. Lastly, they also looked at cardiovascular death. The median time of follow-up was approximately 4 years in this study. So to begin, the baseline characteristics among the treatment groups were relatively similar, but there were some differences. So the median age of the patients that were analyzed was about 65 years across all three groups. Majority of the patients analyzed were actually male. Only about 26% across all the three groups were female. They had similar body mass index, smoking history, high blood pressure, but patients who had diabetes seems to be about 7.5% among the ezetimibe treated group, but a significant portion seem to have been allotted to the no ezetimibe group. Otherwise, a very small portion among them have already had MIs or heart failure at onset. And when looking at their LDL cholesterol at baseline, there were some minor differences between the group, where early ezetimibe group, the starting cholesterol, LDL cholesterol was 147 milligram per deciliter. The late ezetimibe group was around 139, and the group that didn't receive ezetimibe, their baseline cholesterol was about 120. So these were the main, some of the main factors I thought that stood out within the study. So the authors analyzed the data to about 3 years out, and one things they found was that significantly large portion of the patient population achieved the target LDL cholesterol reduction of 55 for this study within 1 year, compared to the group that was not started on combination therapy. So in this graph, the brown line indicates the group that did not receive any Zetia. And as you can see, within 1 year, less than 40% have achieved this target LDL cholesterol. The purple line is the late Zetia group. And again, there's not a significant difference at 1 year time point. And green line is the early Zetia group. And in this, as you can see, that within 1 year, approximately 60% of the patient have reached their target LDL cholesterol of less than 55. And this kind of pans out over the next 3 years. And the curves, as you can see, stayed differentiated over that 3 year time period. The authors also report the changes from baseline amongst the three groups. And as you can see that in the early Zetia group, there was a pretty significant reduction in LDL cholesterol, about decrease of about 89 milligram per deciliter, compared to the late Zetia group, about 77 milligrams per deciliter, and no Zetia, about decrease of 58 milligram per deciliter on simply high intensity statin alone. Another thing that kind of stands out in the data is, as shown in the previous graph, that LDL cholesterol less than 55 and greater than 50% reduction overall was achieved in the early Zetia group, but the most significant effect was in the early Zetia group compared to in the later Zetia and no Zetia group. Moving on to another result that the authors share is that there was a significant decrease in MACE in patients who were started on lipid-lowering therapy earlier with Zetia. So when looking at proportion of MACE at 1 year, the patients in the early Zetia group kind of start to separate out from patients who didn't agree with Zetia or received it late. And this kind of holds true over the next 3 years. The risk difference between the early Zetia and no Zetia group is about 1.9% at the 3-year mark. The authors also looked at proportion of cardiovascular death and proportion of all-cause death over the 3-year period. When looking at cardiovascular death, again, it stands out that the early Zetia group had significantly less cardiovascular death starting within the 1-year time period, and it plays out over the next 3 years with a risk reduction of about 0.8% at the 3-year time point. And similarly, when looking at all-cause death, the earlier Zetia group has a significant decrease in all-cause death at 1-year time point, and it stands out also at 3-year time point, with the absolute risk reduction of about 1.6% by 3 years. Authors further looked at the subdivisions within MACE, looking at non-fatal MI and non-fatal strokes. Surprisingly, there was not a significant difference in non-fatal MI between the 3 groups at the 3-year mark, but there was a significant difference in non-fatal stroke between the no Zetia group and the early Zetia group. About a 0.8% absolute risk reduction at 3 years. This table presented by the authors basically looks at what would happen if the 35,000 patients that were recruited into the part of the trial, if they had all become part of the early Zetia group. And they show that if all of them had received early Zetia, about 477 events could have been prevented. And in the hypothetical situation, if this was projected out to about 250,000 patients, they estimate that about 3,300 events could be prevented with early Zetia initiation. When looking at number needed to treat, early combination therapy leads to about the number needed to treat is about 53 to prevent 1 MACE over 3-year time point, and with late combination therapy, the number needed to treat was 143 to prevent 1 MACE event. So just my critique of this study. This was an observational study. There was absence of randomization, which could have led to different confounding biases where patients were not completely balanced in their characteristics at the onset, and the baseline risks were not appropriately adjudicated between the different groups. Likewise, there is a immortal time bias that's present within this study, as the timing of treatment initiation and the start of the study follow-up don't necessarily coincide. And there were too few patients that were discharged on combination therapy from at the in-hospital admission for them to actually make that cohort part of analysis. And so they had to group everybody into this early Zetia group to make the study reach statistical significance. So in just summary, what I presented today is that the 2025 guidelines in management of acute coronary syndrome recommend initiation of high-intensity statin at time of an ACS event with a target LDL cholesterol of less than 70. It's a class 2B recommendation to start Azetia with the high-intensity statin. It's recommended to reassess lipids within the 4 to 8 week period following this ACS event and add Azetia if the LDL cholesterol is still greater than 70, or another lipid-lowering agent if the LDL cholesterol is between 55 and 69. I presented 2 different clinical trials that kind of set the stage for combination therapy. The Improve It trial basically showed the addition of Azetia to simvastatin therapy after an acute coronary syndrome reduces LDL cholesterol and cardiovascular events by 6%. And in the Odyssey Outcomes trial that looked at PCSK9 addition to high-intensity statin, and it also showed that there was a significant reduction in cardiovascular death, MI, and stroke after combination therapy. And in this Sweetheart registry analysis also kind of confirms similar observation that starting of Azetia early on after an ACS event helps to reach target levels of LDL cholesterol less than 55, and also lead to better heart outcomes such as decrease in cardiovascular events and morbidity within the first 3 years of an ACS. And I'll take any questions.
Thanks, Talha. We've got like 2 minutes left, so we'll open it up for comments and questions.
Hey, Talha, it's Mariana. Great job. I sent a little picture on the chat. You know, working with me at the VA during consults, how much of a Azetia fan I am. And I think this was great data that you presented. You know, like I've discussed this with a lot of my clinic fellows. You know, our first hunch always is to double your statin dose, but I always try to teach fellows that, in fact, after the initial dose, doubling the statin dose reduces LDL only like an additional 6% of the baseline value. I was taught this during my internal medicine training as a like statin rule of 6. So if you see the picture I shared, suppose my LDL is 200, you start me on 20 of pravastatin, that dose reduces my LDL to 25%. So my LDL goes from like 200 to say 150. And then I go back to clinic, and then, you know, my clinician decides to double my dose to Prava 40. Doubling that Prava 40 is not going to produce an additional 50 milligram over deciliter decrease. It's only going to reduce an additional 6% of the 200 baseline. So it's only going to reduce it by like 12 milligrams over deciliter. So my LDL might go from 150 to 138, right? And this reduction with doubling of the statin is even less at higher doses of the most potent statins like rosuvastatin, right? Whereas Zetia decreases, like you said, the intestinal absorption. Adding Zetia is actually going to produce a 20% reduction in your LDL when used alone. And when combined with the statin, it's a 24% reduction, right? So I think in general, we underutilize Zetia. You know how much of a fan I am, so thank you for presenting this.
Yeah, no, thank you for sharing this graph. And yeah, I agree. I think it kind of has been, you know, will be practice changing for me as well. I think I haven't paid attention as much to starting Zetia early enough after an ACS. So moving forward, you know, it'll be important for me as well.
All right, thanks, Talha. We're at the top of the hour, so we'll finish up there, and thanks, everyone.
The preceding program is copyrighted by Emory University.